If you are over 70 and your lower back hurts, you are in very large company. Lower back pain is one of the most common health complaints in adults over 70 in the entire world. And yet, despite how common it is, despite how many people are living with it, the conversation most older adults have with their doctor about their lower back pain is often brief. It is often reassuring in a general way without being specific. And it often ends with some version of, it is your age, or it is arthritis, or try to stay active. And while staying active is genuinely good advice for most people with lower back pain, the rest of that conversation leaves out something important. Lower back pain in adults over 70 is not one thing. It is not a single condition with a single cause and a single management approach. It is a symptom that can arise from several completely different structures in the lower back and spine with different characteristics, different patterns, and different implications for treatment and for health. And the reason that matters is that knowing which specific cause is driving your pain changes what is actually done about it. And in some cases, changes what else needs to be checked and how urgently I am Dr. Daniel Chen. And today I want to walk you through the most common causes of lower back pain. In adults over 70, what makes each one different, how doctors tell them apart, and the specific warning signs that mean your back pain deserves prompt medical attention rather than watchful waiting. So let us start with some anatomy, because understanding the structures of the lower back is what makes the rest of this make sense. The lumbar spine is the lower portion of the spinal column, consisting of 5 vertebrae labeled L1 through L5. These 5 vertebrae are the largest in the spine because they bear the most weight, supporting the full load of the trunk, arms, and head with every movement you make between each pair of vertebrae. There is an intervertebral disc, a structure with a tough fibrous outer ring called the annulus fibrosus, and a softer gel-like center called the nucleus pulposus. The discs act as shock absorbers, distributing force evenly across the vertebral surfaces at the back of each vertebra. On each side are small joints called facet joints or zygapophygeal joints. These joints guide and limit the movement between vertebrae, and they are true synovial joints with cartilage and a joint lining that can develop arthritis. Just like any other joint, through the center of the spine runs the spinal canal, which contains the spinal cord and the cauda equina, the bundle of nerve roots that exits the canal at various levels through openings called foramina. Between the vertebrae, these nerve roots supply sensation and motor control to specific areas of the legs. Buttocks and pelvic region surrounding the spine are the deep stabilizing muscles of the lumbar region, including the multifidus and the transversus abdominis, which provide moment-to-moment stability to the lumbar vertebrae during all movement, and the larger global muscles, including the erector spinae and the quadratus lumborum, that generate the larger movements of the trunk. Pain in the lower back can originate from any of these structures. The discs, the facet joints, the muscles and tendons, the nerves, the bones themselves, or from structures outside the spine entirely that refer pain to the lower back. Now let us go through the most common causes in adults over 70, one by one. The first, and one of the most common, is lumbar facet joint arthritis, also called facet joint syndrome or lumbar spondylosis. The facet joints of the lumbar spine, like all synovial joints, can develop osteoarthritis. With age, the cartilage covering the joint surfaces wears, bone spurs form, the joint capsule becomes inflamed, and the joint loses its smooth, painless movement. Facet joint arthritis pain has a characteristic pattern that is often recognizable. When described carefully, it is typically felt in the lower back, centrally or slightly to one or both sides of the midline. It tends to be worse with extension movements, bending backward, and with rotation, twisting movements, bending backward. It is often worse after prolonged standing or walking, and is typically relieved by sitting or by flexing forward. Morning stiffness that eases with movement over the course of 15 to 30 minutes is characteristic. And unlike disc-related pain, which I will describe shortly, facet joint pain does not typically radiate below the knee. It may refer into the buttocks or upper thigh, but the referral is diffuse and aching. Rather than sharp and radiating in a specific nerve distribution, facet joint arthritis is extremely common in adults over 70 and is often visible on spinal imaging as part of the general changes of lumbar spondylosis. Management includes physiotherapy, core strengthening, activity modification, appropriate analgesia, and in some cases, image-guided facet joint injections, or a procedure called radiofrequency ablation that can provide longer-lasting pain relief by interrupting the pain signals from the affected joints. The second cause is lumbar disc degeneration and disc-related pain. The intervertebral discs undergo significant changes with age. The water content of the nucleus pulposus decreases, making the disc less elastic, less effective as a shock absorber, and more vulnerable to mechanical stress. The annulus fibrosus develops small tears and weaknesses over time, and the disc loses height as its water content decreases. This loss of disc height is visible on X-ray as reduced space between vertebrae and contributes to changes in the mechanics of the entire spinal segment, including increased load on the facet joints. Now here's an important distinction. Disc degeneration, which is the structural change I've just described, is not the same as a disc herniation or a slipped disc, although both are related to the disc. Disc degeneration often causes pain through a combination of mechanisms, including the structural changes themselves, the associated inflammation, and the secondary changes in the facet joints and ligaments that occur when disc height is lost. Pain from disc degeneration is typically felt in the lower back and is often worse with flexion movements, bending forward, as opposed to facet joint pain, which is worse with extension. It is often worse with prolonged sitting and relieved by walking or by lying down. A disc herniation occurs when the nucleus pulposus pushes through a weakness in the annulus fibrosus and can press on a nearby nerve root. This pressure on a nerve root produces a very different pattern of pain called radiculopathy or sciatica. When the sciatic nerve or its component roots are involved, radiculopathy produces pain that radiates in a specific pattern down the leg following the distribution of the affected nerve. It is often described as shooting, burning, electric, or like a current running down the leg. It is typically accompanied by other nerve symptoms, numbness, tingling, or weakness in the leg or foot in the distribution of the affected nerve. In adults over 70, disc herniations are less common than in younger adults because the discs, as they degenerate, become less likely to herniate in the classic way, but they do still occur, and the pattern of pain radiating specifically down the leg with associated numbness or tingling is the key distinguishing feature that suggests a nerve root is involved, and that warrants specific evaluation. The third cause, and one of the most clinically important in adults over 70, is lumbar spinal stenosis. Spinal stenosis refers to narrowing of the spinal canal, or the foramina, through which the nerve roots exit in the lumbar spine. This narrowing is caused by a combination of factors that accumulate over decades. Disc height loss, which causes the vertebrae to settle closer together. Facet joint enlargement due to osteoarthritis, thickening of the ligamentum flavum, a ligament that runs inside the posterior spinal canal, and in some cases, disc bulging. Together, these changes reduce the space available for the nerve roots of the cauda equina within the canal, and when these nerve roots are compressed, a very specific and recognizable pattern of symptoms develops called neurogenic claudication. Neurogenic claudication is one of the most characteristic and diagnostically important symptom patterns in lumbar spinal stenosis. It involves pain, achiness, heaviness, or cramping in the buttocks, thighs, and legs. That comes on with walking or prolonged standing, and that is specifically relieved by sitting down or by leaning forward, such as leaning on a shopping trolley, or bending slightly at the hips. This postural dependency of the symptoms is the key feature that distinguishes neurogenic claudication from the leg pain of peripheral arterial disease, which is called vascular claudication, and which is relieved simply by stopping rather than by a specific posture. In neurogenic claudication, the forward flexed position relieves symptoms because flexion of the lumbar spine slightly opens the spinal canal and reduces the compression on the nerve roots. The classic description from patients with neurogenic claudication is that they can walk much further when they are pushing a shopping trolley or walking uphill, where the spine naturally flexes slightly, than when walking upright on flat ground. Lumbar spinal stenosis is diagnosed by clinical assessment and confirmed by MRI. Management ranges from physiotherapy and core strengthening through epidural steroid injections to surgical decompression in severe cases where conservative treatment has not provided adequate relief. The fourth cause is osteoporotic vertebral fracture, osteoporosis, the condition in which bone density and bone strength are significantly reduced, is extremely common in adults over 70, particularly in women, although it is also prevalent and significantly underdiagnosed in older men. When bone density is sufficiently reduced, the vertebral bodies, the main block-like portions of the vertebrae, can fracture without significant trauma, sometimes with no more force than the compression of everyday activities. Bending forward, coughing, or even just the accumulated load of normal weight bearing. These are called vertebral compression fractures, and they are far more common in adults over 70 than most people realize. The typical presentation of a vertebral compression fracture is a sudden onset of severe localized back pain at a specific point in the spine, often following a specific moment, a bending movement, a cough, or simply getting up. Although in some cases, there is no clearly identifiable trigger, the pain is typically severe and well localized to a specific level of the spine, rather than diffuse, and it is often significantly worse with any movement and improved by lying flat. However, some vertebral compression fractures present with milder or more gradual pain, and some are essentially asymptomatic, discovered incidentally on imaging done for other reasons. When multiple vertebral fractures occur over time, they can lead to progressive forward rounding of the spine called kyphosis, which further alters spinal mechanics and can contribute to ongoing pain, loss of height, and reduced respiratory function. In severe cases, osteoporotic vertebral fractures are diagnosed by X-ray or MRI, and their occurrence should always prompt assessment of bone density, if not already done, and review of osteoporosis management, including medication, if not already appropriately treated, because a vertebral fracture is a significant clinical event that substantially increases the risk of future fractures, including hip fractures. The fifth cause is piriformis syndrome and sacroiliac joint dysfunction. The piriformis is a small muscle deep in the buttock that runs from the sacrum to the upper femur, and the sciatic nerve passes either beneath it or, in some people, through it. When the piriformis muscle is tight, inflamed, or in spasm, it can irritate the sciatic nerve, producing pain that radiates from the buttock down the back of the thigh in a distribution very similar to true sciatica. From a disc herniation, this is called piriformis syndrome, and it is distinguished from disc-related sciatica by the absence of back pain. As the primary complaint, the localization of pain and tenderness to the buttock, and specific physical examination findings. Similarly, the sacroiliac joint, where the sacrum meets the pelvis, can be a significant source of lower back and buttock pain. In older adults, sacroiliac joint pain typically presents as pain in the lower back or buttock on one side. That is often worse, with transitional movements, getting up from a chair, rolling in bed, climbing stairs, and can be reproduced with specific provocation tests. During a clinical examination, both piriformis syndrome and sacroiliac joint dysfunction are managed with physiotherapy, and in some cases, image-guided injections. The sixth cause that I want to discuss is non-spinal causes of lower back pain. This is something that I want every older adult with lower back pain to be aware of, because it is both important and frequently overlooked. Several conditions outside the spine can refer pain to the lower back in ways that can be mistaken for a spinal cause. Kidney conditions, including kidney stones, urinary tract infections, and kidney disease, can cause pain in the flank and lower back. That may be difficult to distinguish from spinal pain without specific investigation. Abdominal aortic aneurysm, a dilation of the main artery in the abdomen, is significantly more common in men over 65 and can cause deep back pain. That does not fit the typical pattern of mechanical spinal pain. This is a condition that has specific red flag features that I will describe shortly, and that requires urgent evaluation. Pancreatic and other retroperitoneal conditions can also refer pain to the lower back, and prostate conditions in men can sometimes present with lower back pain as a component. This is why lower back pain that does not follow a recognizable mechanical pattern, that does not respond to the usual management, or that is accompanied by other unexplained symptoms, deserves investigation beyond just a spinal assessment. Now let me talk about the red flags. The warning signs that mean lower back pain in an older adult requires prompt medical attention rather than a watchful waiting approach. These red flags are, in medical terms, features that increase the probability of a serious underlying cause that needs urgent evaluation. The first red flag is severe, unremitting pain that is not relieved by rest or by lying flat. Pain that is worse at night or that wakes you from sleep is particularly significant because mechanical back pain usually improves with rest. Pain that does not improve with any position or that is actually worse at night should not be attributed to a mechanical spinal cause without further investigation. The second red flag is recent significant trauma, a fall, a road traffic collision, or any significant impact. In an older adult with osteoporosis, even relatively minor trauma can cause a vertebral fracture and should be assessed. The third red flag is unexplained weight loss that the person cannot explain by a change in diet or activity associated with back pain is a concerning combination that raises the question of whether something other than a spinal mechanical cause is involved. The fourth red flag is bladder or bowel dysfunction, new difficulty passing urine, or loss of bowel control. Associated with lower back pain is a potential sign of cauda equina syndrome, a serious neurological emergency in which the nerve roots of the cauda equina are severely compressed. This requires emergency medical assessment without delay. The fifth red flag is fever associated with back pain, which raises the possibility of spinal infection or a systemic infective cause. The sixth red flag is back pain in someone with a known history of cancer, as cancer can metastasize to the spine and cause back pain through a completely different mechanism than mechanical spinal disease. And finally, the seventh red flag is back pain accompanied by the pulsating sensation in the abdomen or severe tearing abdominal pain radiating to the back, which may indicate an aortic aneurysm and requires immediate emergency evaluation. None of these red flags are reasons to panic, but they are reasons to call your doctor today rather than waiting for a routine appointment. Now let me bring everything together. Lower back pain in adults over 70 is extremely common, but it is not one thing. The most common causes are lumbar facet joint arthritis, which is typically worse with extension and prolonged standing and relieved by sitting. Lumbar disc degeneration, which is typically worse with flexion and prolonged sitting. Lumbar spinal stenosis, which causes neurogenic claudication, pain with walking, relieved by sitting or leaning forward. Osteoporotic vertebral fracture, which causes sudden localized pain at a specific spinal level. Piriformis syndrome and sacroiliac joint dysfunction, which cause buttock and lower back pain with specific movement triggers, and non-spinal causes, including kidney, vascular, and other conditions that refer pain to the lower back. Each has a different pattern, a different examination finding, and often a different imaging requirement, and several require different treatment. The red flags: severe night pain, trauma, weight loss, bladder or bowel dysfunction, fever, known cancer, and pulsating abdominal pain require prompt medical attention, not watchful waiting. If you've been told your lower back pain is just arthritis or just your age without a thorough clinical assessment that considers the specific pattern of your pain and whether any further investigation is needed, I want to encourage you to have a more detailed conversation with your doctor. Tell them where specifically the pain is, when it is worst, what makes it better, what makes it worse, whether it radiates anywhere, and whether you have any of the red flag features I have described. You deserve a proper assessment, not a reassurance, and you deserve to understand what specifically is driving your pain so that what is done about it has the best possible chance of actually helping. I am Dr. Daniel Chen. If this video helped you understand that your back pain may be more specific and more addressable than you have been led to believe, please share it with someone over 70 who has been told it is just aging and has accepted that when they deserve more. Subscribe to this channel for weekly videos made with genuine care for older adults who deserve real information about their own health, and leave me a comment below. Tell me what your lower back pain feels like and whether you have had a thorough assessment or whether the conversation ended with, "It is just arthritis." I read every single comment and I genuinely look forward to hearing from you. Take care of your back and take care of yourself. You deserve real answers.